Ecco, benvenuti al corso.
Welcome to this course on physiological regulating medicine. With today's lesson, I shall begin to talk about internal medicine, and the first of these lessons is dedicated to the ear, nose, and throat.
La caratteristica di tutte le mie lezioni sarà quella di proporre una serie di patologie.
The characteristic features of all these lessons will be that we shall examine a set of diseases, proposing general drugs for their treatment, and, in addition to these general drugs, i.e., that are specific for a given disease, we shall also recommend pharmaceuticals, usually cytokines or hormones, that represent the great novelty of physiological regulating medicine, with which we seek to regulate the more precise aspects of the therapy in a focused manner.
Gli aspetti più precisi della terapia. Iniziamo il primo punto, iniziamo con una patologia che è apparentemente banale.
Let's begin with an apparently bland disease, but one that often poses far from negligible problems to the patient involved, i.e., rhinitis. We all know what rhinitis means. It means nasal secretions and inflammation of the nasal mucosa. But not many people know that it is very important to understand whether this rhinitis stems from a mainly allergic component, and there are also perennial allergies such as dust mite allergy, or whether this rhinitis is prevalently viral in origin because, depending on the prevalence of these two factors, we will need to take a completely different therapeutic approach. We know that, in viral disease, the culprit is a DNA-type virus, a family of viruses capable of causing major inflammatory problems that also correlate with low levels of interleukin-10 that should normally, but in these cases do not succeed completely, to stop the inflammatory process. What does this mean? It means that in viral rhinitis, the characteristic element of the cytokine-based therapy that is typical of our physiological regulating medicine will be the administration of interleukin-10, which is capable of slowing the inflammatory process. Vice versa, in the case of an allergic rhinitis, we shall have high levels of other interleukins, e.g. interleukin-5, and the therapeutic approach must consequently be completely different. It must be based on administering a rebalancing interleukin, such as interleukin-12, for instance, that we use in a physiological concentration. 4C, i.e. in small quantities, for all allergic conditions. So what is the basic treatment for rhinitis? Let's say that, generally speaking, the basic drug is Guna-Rhino nasal spray, which has a remarkable anti-inflammatory and decongestant effect. And we can use 2 sprays for nostril 2 or 3 times a day, depending on the symptoms. This is a drug that copes very adequately with the symptoms of both allergic or viral origin. Since congestion is an important factor in both the allergic and the viral forms of rhinitis, drainage is important too. We shall achieve this drainage by using Guna Lympho. So, we prescribe 20 drops of Guna Lympho morning and evening for patients predisposed to develop viral or allergic rhinitis. Guna Lympho is fundamental in both the acute phase of the disease, when we shall also use Guna Rhino, which is only useful in the acute phase, and in the prophylactic phase to prevent the disease. Then, of course, again in the acute phase, and especially in cases of viral disease, we shall also prescribe Guna Flu. Among the remedies of physiological regulating medicine, with an antiviral action, Guna Flu is specific for influenza and para-influenza viral infections. As we were saying, in the case of symptoms stemming from a disease that is presumably of viral type, secondary to a cold for instance, occurring in the winter season, etc., then we shall also administer interleukin-10 4C, that we shall use in doses of 10 to 20 drops according to the patient's age, 2 or 3 times a day, depending on the symptoms. Nasal polyposis is a disease that has become very frequent nowadays, related not only to allergic problems, as we might commonly believe, but also secondary very often to a recurrent inflammation of the upper airways, sometimes caused by pollution, sometimes by relapsing infectious conditions. The fact remains that many patients suffer from nasal polyposis. The treatment is usually based on topically administered cortisone that, as we know, can have many side effects, not only locally but also systematically, particularly if it is used for a long period of time. The alternative is surgery, and we can see that surgery very often has to be repeated, something that poses numerous problems for the patient. The approach of physiological regulating medicine has been to seek to fully understand the problem of polyposis, understanding first of all that polyposis has a multifactorial origin, rooted above all in a specific inflammatory phenomenon at the level of the paranasal synesis in specifically predisposed individuals. Starting from this concept, we have arrived at the therapeutic solution that, by physiological regulating medicine, which consists first and foremost, as is always the case in all the protocols that we recommend, of a basic drug specific for the condition, that in this case is Guna Sinus nasal spray, an extremely effective drug. Some people have even said in the past that it is too strong, in the sense that it is genuinely a pharmaceutical that stimulates the reactivity of the mucosa. Of course, as always, we must also ensure the drainage of the structures, which is achieved with Guna Lympho, as usual, with 20 drops morning and evening, even for extended periods of time, and since polyposis is an inflammatory condition, a hyperinflammation specific to an individual, it will very often be necessary to add 20 drops of Guna Flam in association with the Guna Lympho morning and evening for lengthy periods, particularly in those subjects who have a basic inflammatory tendency. What shall we associate with these basic drugs? We shall add anti-interleukin 1,4C, which controls the problems related to the inflammatory hyperreactivity typical of these patients, and what makes them tend to develop polyposis, be it of allergic origin or a bacterial or inflammatory origin. And we shall administer 10 to 20 drops of this anti-interleukin 1,4C, as the case may be, 2 or 3 times a day for periods of 2 or 3 months, after which, once the acute phase has been overcome, when the polyposis is no longer in its severe clinical form, we can maintain only the basic therapy with Guna Lympho, 20 drops morning and evening. Sinusitis, and chronic sinusitis in particular, is an extremely common disease, especially in our regions, and above all in the polluted environment of the Western world. As always, we have to distinguish what types of disease we are dealing with, here again analyzing the situation from the physiopathological standpoint. True to the style of physiological regulating medicine, we can identify 2 main types of sinusitis: infectious sinusitis and a type of sinusitis that is not infectious, but characterized by a completely different, specific reactive response of the body.
Non infettiva, caratterizzate da un atteggiamento reattivo dell'organismo completamente specifico.
In infectious sinusitis, there will be higher levels of interleukin-8, an interleukin capable of triggering a severe reaction of the local inflammatory type. In cases of sinusitis that have an allergic component, on the other hand, we shall have a specific increment in interleukin-5. There are therefore 2 specific immunological and hematopochemical situations that will enable us to characterize the immunological pattern of the various types of sinusitis. To tell the truth, the therapeutic protocol that we recommend using physiological regulating medicine is very straightforward because it can cover both these pictures. The basic drug will be the one that I mentioned before for cases of polyposis, another inflammatory condition of the nasal cavities, and that is Guna Sinus nasal spray, which must be used especially in the symptomatic phase and also for prevention in the winter and particularly cold periods.
O anche in prevenzione nei periodi invernali e particolarmente.
So, 2 sprays per nostril 2 or 3 times a day. Here again, it is usually essential to ensure proper drainage with Guna Lympho. So patient must achieve this drainage with Guna Lympho. 20 drops morning and evening, starting in September, for instance, and continuing until March. so that the structure of the paranasal sinuses is always suitably drained. Here again, it is also extremely important to reduce the inflammatory reactivity of the sinus epithelium with Guna Flam. The interleukin that we should use in these cases is a highly characterized interleukin that is often lacking in patients with chronic sinusitis, be it of allergic or infectious typology, and that is interleukin 2. The characteristic feature of interleukin 2 lies in that it is the Th1 interleukin and consequently extremely useful in shifting the balance in allergic patients who have an imbalance towards the Th2 in their Th1-Th2 balance. But it is also interesting to patients with chronic infectious sinusitis because it activates the defensive clones, body immune cell clones, and it is consequently also extremely valid as a drug in this type of sinusitis. We shall use 10 to 20 drops of interleukin 2,4-C 3 times a day, bearing in mind that this interleukin stimulates the growth of the hematopoietic cells, and so there are some cases, e.g. patients with leukemia or chronic myeloma, in which we must avoid stimulating this type of cell growth because it is already exuberant. To sum up, therefore, basic drainage with Guna Lympho, very important to tissue drainage, and an anti-inflammatory drug if the patient has mucosal inflammation. So not only in this acute phase, but also in the subacute phase, and that means Guna Flam, a drug for the acute phase, Guna Sinus nasal spray, and the interleukin that regulates immune reactivity in patients suffering from chronic sinusitis, either of allergic or of inflammatory infectious types, i.e. interleukin 2, 4C. Tonsillitis is an extremely common disease in the ENT field. We know that in the past, children very often underwent surgery only too easily following repeated episodes of tonsillitis. Nowadays, however, children are often given repeated cycles of antibiotics. As a result, it is due to tonsillitis that they develop intestinal divobiosis, triggering a whole series of diseases that can even be extremely severe and invalidating, and also have a fallout on their adult lives. It is consequently extremely important for us to thoroughly understand the problem of tonsillitis from the diagnostic and physiopathological point of view, and that we treat it adequately. There's a great deal of confusion surrounding this issue. First of all, we need to know that when we speak of tonsillitis, we must first establish whether it is a case of acute tonsillitis, which is what we see most often, or of chronic tonsillitis. But within the context of acute tonsillitis, we must distinguish extremely clearly between bacterial tonsillitis, which is usually streptococcal, and viral tonsillitis. How do we distinguish between them? We can generally distinguish between them on the strength of certain clinical features. Bacterial tonsillitis is characterized by a very high fever and tonsil plaques, whereas in viral tonsillitis, we very often find a lower body temperature. But patients are more often exhausted. They will have a typical dryness of the mucosa, and very often we shall see a more accentuated lymphnode enlargement.
Ci sono degli ingrossamenti linfonodali più accentuati.
We need to remember that. In viral tonsillitis, we may see cases of viral tonsillitis that are, in a sense, benign, i.e., related to an adenoviral infection. Or there may be more dangerous cases of viral tonsillitis, i.e., in cases of viral tonsillitis associated with Epstein-Barr virus. So we must be very careful because a viral tonsillitis due to Epstein-Barr virus, a virus that, once it has penetrated inside the body, remains latent and is impossible to eliminate. This type of viral tonsillitis can be numerous, even extremely severe outcomes, among which I must just mention lymphoma and leukemia. And these are diseases that we encounter in young people and children, but also numerous cancers, e.g. of the nasopharynx, that mainly affects adults. It is therefore terribly important to classify a case of tonsillitis. We know that if a tonsillitis is a case of bacterial tonsillitis, we may very often have to resort to antibiotic therapy. We must not be afraid to use an antibiotic if our tonsillitis is streptococcal. And we shall associate the antibiotic therapy with our own treatment. The antibiotic serves to kill the microbe while we work on the terrain. So what do we do in cases of common bacterial tonsillitis? We shall use the classic drug with an anti-inflammatory action, Gunaflam, that is prescribed in the classic dosage of 20 drops 2 or 3 times a day. We shall associate this with a lymphatic drainage drug, Gunalympho. In cases of bacterial tonsillitis in predisposed individuals who therefore have recurrent bouts of bacterial tonsillitis, the best drug to use for our recurrent bacterial tonsillitis is this Gunalympho. And, of course, a great drug to use specifically in such cases, both for prevention and for treatment, in quantities of 5 to 10 granules morning and evening, is Cedomix, the specific composition of which is effective in both bacterial tonsillitis and in viral tonsillitis. We must remember, however, that in bacterial tonsillitis, we must obviously still resort to an antibiotic. The interleukin that we shall use for cases of bacterial tonsillitis is very particular, i.e., it will be interleukin 8-4C, the level of which is specifically increased in this disease. So why should we use an interleukin that the body already increases on its own? We use it because the body raises its levels to activate this antibacterial defenses in particular, and so we go in the same direction as the organic response in order to help it recover more quickly and effectively from the disease.
In maniera più veloce e più valida dalla patologia.
Now let us spend a few words on the tonsillitis, or pharyngitis, as we prefer to call it, due to mononucleosis.
Appunto alla mononucleosi.
The Epstein-Barr virus is an extremely important virus, a DNA virus that, like all the DNA viruses, causes a whole series of problems. The most important problem may be fever, fatigue, but very often the Epstein-Barr virus also causes hepatitis, and so it is a virus that poses really important problems.
Quindi è un virus che crea dei problemi veramente importanti.
Individuals who suffer from mononucleosis should rest, in my opinion, even for a period of 2 or 3 weeks, because, being a virus of the herpes virus family, it tends to include a specific immunosuppression, and it tends to produce a substance very similar to interleukin 10 that suppresses the body's immune system's capacity to react.
Tende a produrre una sostanza molto simile all'interleuchina 10 che immunosopprime la reattività.
So we are faced with a very complex situation. We have seen before the case of rhinitis where the epidemiological agent is the rhinovirus, which is an RNA virus. And all the RNA viruses have a particular feature, and that is that they prompt a marked inflammatory reaction. So in rhinitis and sinusitis, we very often have to deal with a powerful inflammatory reaction. And as we have already seen, we have to use Gunaflam and the anti-interleukin 1,4C and so on. But in the case of the DNA viruses, however, and these are the adenoviruses, but especially the viruses causing mononucleosis, we must instead stimulate such an inflammatory activity because we are dealing with diseases in which there is often no very high fever, often no very remarkable symptoms. But it is especially when there is no high fever, when there are no remarkable symptoms, that we have a latent underlying disease that can lead with time to extremely severe problems. So it must be clear that mononucleosis infections need to be identified whenever they might be suspected, and our suspicions might be aroused by the fact that these patients have swollen lymph nodes, fatigue, hepatomegaly, and so on. And it must be identified and cured with great care. We must remember specifically if we suspect an infectious mononucleosis that, I must emphasize, is an extremely dangerous disease even for children. Many of the cases of leukemia that we have seen in children will have begun with a bland Epstein-Barr viral infection. So our key drug will be interferonomin gamma 4C, that we shall associate with Cytomix, which is extremely important. The dosage will be 10 to 20 drops of interferon gamma 4C 2 or 3 times a day, and we shall administer 5 to 10 granules of Cytomix twice a day. The two drugs must be associated together. In this case, we shall also need GunaCell, i.e. a reactive stimulus for the cell, so we can administer 10 to 20 drops of this powerful drug twice daily, which stimulates cell reactivity. Very often, we are sure that we are dealing with a case of infectious mononucleosis, and we suspect that the patient is not coping adequately, and we can properly tell because the patient suffers from severe asthenia, that we must also take action with transfactor. We have the Guna transfactor herpes that consequently works on all the herpes viruses, so this goes for chickenpox to herpes simplex to herpes zoster, but also to cytomegalovirus and Epstein-Barr virus. We must rely on the capsule of Guna transfactor herpes to be taken daily for 5 days a week for at least 3 weeks. As for the cytokines, we must bear in mind our most powerful weapon, the most powerful weapon at the body's disposal against viral diseases, i.e. interferon gamma that, as we have already said, needs to be administered at a dosage of 10 to 20 drops 2 or 3 times a day until the acute phase is over. In conclusion, I would like to emphasize the point that all too often, cases of tonsillitis due to infectious mononucleosis, which are much more severe and difficult to cure, are mistaken for a bland case of tonsillitis.
Abbiamo parlato di tonsillite acuta, ora è molto importante parlare...
So far we have talked about acute tonsillitis, now it is important to talk about chronic tonsillitis instead. Chronic tonsillitis may be a recurrent form of tonsillitis. We very often see children who have had several episodes of tonsillitis, in which case we speak of recurrent tonsillitis, and, in a picture of hyperreactivity due to these continuous superinfections, the tonsils develop a larger than normal tonsil mass. In such cases, of course, treatments must be continued for a prolonged period of time and will be based mainly on 2 drugs that we have already mentioned previously. Guna-Lympho, the great drainer of the hypnotic tissues, clearly this is the basis of this therapy. So we should use 10 to 20 drops daily for lengthy periods of time, even 6 to 7 months in any given year, because then we shall slowly see a modification of the architecture of these anatomical structures. We shall also add GunaFlam to reduce this local inflammatory tendency, a tendency that is no longer a defensive strategy, but a tendency that has negative repercussions on the body. So we can use 10 drops of GunaFlam and of Guna-Lympho morning and evening for extended periods. During the times of year when the patient is more likely to become ill due to contingent factors, epidemics, local factors, nursery school attendance, and so on, we should associate Cytomix with these 2 basic drugs, prescribing 5 granules morning and evening, even in the long term, so as to restore the body's immune balance. This does not necessarily rule out the use in such cases of cytokines too, and the cytokine for recurrent inflammation for any excess triggering of this mechanism is anti-interleukin-1. So very often, especially in the acute stages, we shall also add 10 drops of anti-interleukin-1 4C morning and evening. There are cases, however, in which recurrent inflammation is not the most important issue. Children may not necessarily become ill, but when we examine them and discover that their tonsils are swollen, even almost obstructing the ostium, in these cases of pure hypothropic tonsils, it is no longer just an inflammatory problem, and the child may not seem ill, but may snore at night or breathe with great difficulty. It is no longer a question of an acute type Th1 inflammatory response. That is typical of recurrent tonsillitis, but it is a type Th2 inflammatory response. We need to bear in mind that the Th2 lymphocytes tend to keep the cell alive, not to destroy it or attack it, and thereby make it hypertrophic. So it is a completely different immune response and we will consequently not see a major inflammatory problem. We will see a hypertrophic response of the tissues. In this case, therefore, the therapeutic approach might be completely different. We shall have to use a cytokine that shifts the reaction towards cell destruction and tissue cleansing, such as interferon gamma. So in these children, we shall use 10 drops of interferon gamma 4C morning and evening, and this will tend to dry out the lymphatic tissues. We shall associate this with a basic drug, which will be Guna-Lympho, and we shall add a new drug for the pediatric setting in the ENT field. That is one of the pivotal drugs of physiological regulating medicine, and never more important than in these cases, i.e. Guna matrix, so as to work specifically on the matrix, to dry out the hypertrophic lymphatic matrix. Here again, we shall use Cytomix to deal with any superinfections of these hypertrophic tonsils, something that is very important because children with hypertrophic tonsils tend to breathe poorly and may have problems with otitis and a whole series of learning disorders that very often require surgery in order to deal with them. This type of therapeutic protocol, protracted for an adequate amount of time, which must be 5 or 6 months, almost always leads to a reduction in the hypertrophic masses of lymphomatic tissues that, we must remember, are often also related to a specific body reactivity.
Il problema più importante che vediamo nei bambini.
The most important problem that we shall see in small children, aged around 1 year or 18 months, and usually up to 5 years of age, is the problem of adenoid tonsil hypertrophy. The adenoid tonsil is an anatomical lymphatic structure found in the upper part of the pharynx and also in direct communication with the nasal fossae, and it is consequently the one that receives, in a sense, the stimulus of pathogens that reflects any problems originating in the nose or from the mouth, so it is very easy for this structure to become swollen in reactive terms, and this consequently gives rise to a whole series of respiratory problems.
Determini tutta una serie di problemi di tipo respiratorio. Il bambino con
Children with adenoid hypertrophy are children that have great difficulty in breathing through the nose, but above all, specifically because of this anatomical position. And here we can see, if this is the nose, the adenoid is here. The hypertrophic tonsil almost always goes to obstruct the Eustachian tube. The Eustachian tube is a small duct that places the pharynx in communication with the middle ear. An obstruction of the Eustachian tube tends to deafness on the one hand or to otitis media on the other. That is, a whole series of problems that include both a poor nervous reactivity and learning delays and sleeping problems and so on, and lack of appetite, that in children can be related to hypertrophic adenoids.
sonno e così via, l'inappetenza possono nel bambino essere legati a una ipertrofia adenoidea.
This is consequently a disease that very often demands surgery, and that has to be treated because, I might add, failing to treat it can lead to structural and anatomical damage to the children's facial features.
Dei danni strutturali anatomici sulla faccia del bambino. Cosa dobbiamo fare anche qui? Allora, il farmaco di base.
What must we do in such cases? Well, the basic drug will be the one that I mentioned a little while ago, Guna matrix. Therefore, we must work in depth on a structure. We must dry out a structure that has a tendency, which is typically constitutional, to become hypertrophic. So we shall administer Guna matrix 10 drops morning and evening for the 2, 3, 4, and 5 months that it takes to see a marked improvement in the symptoms.
Miglioramento netto dei sintomi.
In acute phases, we shall treat our young patients with Guna sinus nasal spray, which is extremely effective in loosening the thick carter that forms in response to the adenoid obstruction, and Cytomix in the acute inflammatory stages related to any viral infections and so on.
Legati a una virose e così via. Anche qui,
Once again, in this case, as I said before, the hypertrophic tonsils, we must stimulate the Th1 response because we are in an imminently Th2 phase. Very often, hypertrophic adenoids are also related to an allergic type of problem. This is the case in individuals who eat foods of which they are intolerant, and we must therefore shift and limit its Th2 hyperreactivity. So we shall administer interferon gamma-4C in doses of 10 drops morning and evening. Correlated with hypertrophic adenoids, as I mentioned a little while ago, there is another condition extremely common in infancy, and that is otis media.
I bambini proprio molto spesso in relazione con l'ipertrofia.
In association with the hypertrophic adenoids and with nasal catarrh, children often reveal tension in the middle ear, a tension in the middle ear that creates a state of primary congestion, followed by pain that is extremely troublesome.
Estremamente problematico, molto spesso, tra l'altro succede.
It is a problem that we see very often. What's more, it occurs at night, when the child is warmer. There is this explosion of very severe pain in the middle ear during the night. Naturally, if it is cured in good time, otis media does not require any antibiotic therapy. Almost always, otis media in the painful, even inflammatory phase is an inflammatory condition but is not septic. So we could say that the concept of otis media is very different from the concept of bacterial tonsillitis. Therefore, if we succeed in taking action at an early stage, we can achieve extremely important results. If we do not take action, there is obviously a tendency for superinfections to develop, and clearly we have to resort to an antibiotic.
Chiaramente intervenire con l'antibiotico. Cosa facciamo nell'otite media? Anche qui.
What do we do in cases of otis media? For otis 2, the emergency drug with which we can take immediate action is Gunaflam. So even during the night, in the course of an acute episode of otis media related to an inflammatory situation of nasopharyngeal type, we administer 10 drops of Gunaflam under the tongue and repeat this even every hour until the acute phase has passed. On the subacute phase, we can then take action with Gunalympho, which must be continued in these children if there is any recurrence of otis media. Here again, we use Cytomix, because it is by preventing the diseases of the nose and throat, especially those of viral type, that we can prevent otis media. We should remember, moreover, that otis media is much more often in atopic subjects, i.e. in individuals who are allergic. So when we see a child who has reoccurrences of otis media, we can already assume, even if there is no evidence of rash, asthma, or allergic rhinitis, that it is a condition of atopic allergic type. And that is why it is very important to take with the great Th1 cycotin, which is therapeutic for allergic individuals, i.e. interleukin 12. So we shall administer 5 to 10 drops of interleukin 12 twice a day in these children to shift their immune balance. Now, what can we say in the PRM setting about diseases of the ear, nose, and throat? We can say that there are basically two major chapters, two gross issues that we must pay attention to. We must distinguish the diseases of inflammatory type from the diseases of the hypertrophic aspect prevails. As concerns the interflammatory disease, we must establish whether they are in an acute phase or in a recurrent phase. So now we have clearly defined all the drugs. In the acute phases, as we have just seen now with otis media, here we have the great fundamental anti-inflammatory drug, Gunaflam. For reoccurrences, the main drug to use will be Gunasinus nasal spray, to put a stop to the recurrence of disease. For the hypertrophic problems here again, we have subacute hypertrophic problems, correlating therefore with an infectious phase, and in this case we must work with Gunalympho, while for the chronic hypertrophic phases, which are subsequently constitutional, we must use Gunamatrix. We should use all these drugs in dosages of 10 drops for children and 20 for adolescents and adults, twice a day, leaving aside the debate on complex medications. The other aspect to consider concerns the use of cycotins that we shall associate, as we have seen, with the complex medication based on the dictates of PRM, for a fine and detailed therapeutic approach. As concerns the use of cyclotins in the ENT setting, we again need to classify the diseases on an inflammatory basis, distinguishing between inflammatory diseases of bacterial origin and those of viral origin. For inflammatory diseases of bacterial origin, we need to stimulate the body to improve its reactivity and innate healing capacity with interleukin 8-4C. So we shall administer this specific interleukin always in the usual doses of 10 to 20 drops 2 or at most 3 times a day. For viral diseases, we must clearly understand whether we are dealing with a DNA-type virus, such as herpes virus, cytomegalovirus, adenovirus, Epstein-Barr virus, and in this case, we shall rely on the strong reactive stimulus of interferon gamma 4C, or whether we have to deal with the milder rhinovirus or influenza-type virus instead, in which case we are talking of RNA viruses that already prompt a marked organic inflammatory response. So in the case, we must take steps to contain the inflammation, and so we shall use interleukin 10-4C instead. So it is quite straightforward, very clear and very schematic. In the hypertrophic phases, on the other hand, we need to modulate the excessive type Th2 response, and so in this situation, we shall use interferon gamma 4C as a tissue reactive stimulus. We have also seen that there is the whole allergic component, all the allergic reactivity again in the Th2 context, and when there is a major allergic component, and this is something we shall identify because it is detectable when patients are sensitive to a given food, or pollen, or any other substance. In these cases, we must always include interleukin 12-4C in the therapy, and make it a protagonist in the treatment because, on the strength of a whole series of experimental studies that have been conducted, it appears to offer a solution in allergic conditions.